You went and you did the thing, and a couple of years later have really found your way in our community as the guy.
So what ends up happening is our body starts perceiving those obsessions or those thoughts or experiences as a threat. When that happens, we're designed to fight or run away from that threat. I always say like OCD and anxiety disorders are resilience killers, right? And confidence killers, because you have these worries and doubts. You do a behavior to try to prevent them. You never get the chance to learn that you could handle the feelings or the situations, whatever they might arise.
And it kills your confidence.
It makes you believe
you don't have a chance to be confident.
Yeah.
Welcome to Look for the Helpers, a podcast by Engage Therapy in Agora Hills, California. Hosted by Adelina Brisbois, licensed marriage and family therapist, and her husband, Dr. Blake Brisbois, licensed psychologist. Thanks for being here.
Good morning, Andrew.
Good morning.
Welcome to our podcast.
Thank you. I'm so excited to be here.
I'm really glad you're here.
Yeah.
So I'm going to do my best to introduce you, and then you'll tell us a little bit more about yourself and your personal journey. So you're Andrew Cohen. You're a local clinician. You and your wife, Danielle, have opened an amazing practice called Cohen OCD Therapy.
Yeah.
Because you and Danielle specialize in obsessive-compulsive disorder and anxiety disorders.
Yep.
You guys work with youth and adults and anybody who is needing that support.
Ages 5 and up.
5 and up, yeah, which is really awesome and unique. And just a little background about how we know each other.
Yeah.
I knew you back in the day when you started at Engage as, what was it, a
program assistant, I guess.
Program assistant.
Yeah.
You did everything, right?
Yeah.
I remember you would drive people to program. You would go pick up stuff that we needed. Yeah. And then, I watched you go to school, get your degree. And then eventually I was able to be your supervisor. Yeah. And that was really awesome and got to know you better that way, clinically and personally. And then I think your story from there really takes off. So I'd love for you to share more about it today.
Sure.
You now are an expert in the community in OCD. So much so that you come and train our staff in how to recognize and, understand OCD better. Yeah. So we're really grateful for that. All of us have learned, including myself, from you and Danielle as well. So let me turn it over to you and tell us a little bit about your journey. Like, how did you get here? Yeah. What was your story?
Absolutely. Well, thank you, everyone, for having me. I'm so excited, and I hope the listeners get a lot out of this today. I've been passionate about being a therapist for a while. I've always dealt with, now looking back, knowing that it was OCD, I would just call it anxiety at the time, a lot of worries. I went to therapy, around 15 years old for a lot of this anxiety. And through that journey, I became passionate, about becoming a therapist and helping others. My OCD, I think, showed up, now looking back, around 7, 8 years old, and really kind of, I named my OCD Bitumen. So Bitumen's kind of, been with me through this journey, if you will. And let's see, I was in talk therapy for a while, went, to it's all good. I was in talk therapy for a while, just throughout high school and kind of into college. And, my anxiety, now looking back, knowing OCD, really kind of hit a peak when I was in my last year at UCLA. And, it really became extremely debilitating. I, was bombarded with, we'll kind of go into what OCD is, I'm sure, in a little bit. But,
Well, you can tell us.
Yeah, we'll go into the definitions and all that. But a lot of my worries or obsessions were around, morality and if I'm a good person or not, and needed to confess a lot of thoughts that I was having. And it was just very consuming. And, luckily I was with a therapist at the time who I think recognized, she's like, I think this is OCD, and, referred me to a specialist, a place called OCD Center of Los Angeles. And, with an amazing clinician, Laura Yoakum. And, I don't know if this sounds dramatic, but it did save my life. I was at a point where if things didn't change, I wouldn't be here right now. It was tormenting. It was 24/7. It would infiltrate my dreams. Man. It's like you never even got a break. You didn't get a break. And, I went and did some really intensive ERP, exposure and response prevention type therapy. And I was going, 2 hours a day, 3 days a week for a while, and it was, individualized and really intense and difficult. But, that's what really led me down the path of, okay, I want to specialize in this, because this was the first time I've experienced therapy where, I left it being able to like actually have, we always talk about tools and skills and stuff, but this was the first time I was able to actually like apply this stuff into my life and
outside of the therapy.
Yeah.
Like you felt relief for the first time, it sounds like.
And not just, so we'll talk about the relief piece of it, not just like temporary relief, like you do a compulsion and you feel better and the worry comes back. Right. But it was more like long lasting, like I would say it was more like content.
Oh, okay. Which is a big deal when someone is struggling with the loop.
Yeah, yeah. So, I was able to finally step outside of that cycle that OCD and anxiety gets you looped into, and being able to actually like be able to see my mind for what it is versus, it was all jerking me around, making me do all these things that I didn't want to have to do. And, it finally was a way to break free from it. So, that's what got me kind of really interested in working with it. When I went to grad school, I was, working at Engage, driving people around, doing all that fun stuff. But the whole time in grad school, I was spending my time researching and reading on OCD, anxiety, ERP. I even went, onto the IOCDF, the International OCD Foundation's website. And there's like a find a provider, function on there, and basically put in my zip code and emailed probably every provider within a 50-mile radius of like, hey, I really want to work with this. Like, what do I need? Tell me what to do. Can I come in? And finally, I was able to find a place out in West Los Angeles called Renewed Freedom Center, where Dr. Jenny Yip runs it, and she's incredible. And I worked there for I think 3 years, opened my own practice out here, and continue to be highly involved in the OCD world. So, trained through the International OCD Foundation, do like the advanced consult groups with them, and I'm actually attending one
in October.
In 2 weeks, I think. Yeah, an advanced pediatric one. I'm so excited. They're so much fun. And I'm just very passionate about this. I love to do podcasts like this to share about this stuff and provide trainings to folks like you and other treatment centers. And I very much value. It is really cool being able to sit here and have this conversation with you.
It is.
Really it's like, what? When was that? 2018, 2019?
Yeah. No, like probably 2017. So almost 10 years. Right?
Wow. Yeah.
Yeah.
Yeah. Whoa.
What, maybe it was 2016. Yeah, something like that.
No, I definitely started in 2016 with Engage.
Right.
But when you actually became my supervisor, I think 2017, 2018. Yeah.
Right. I know.
Yeah, that's just...
In a way, it feels like a long time, but in another way, it really doesn't.
Yeah.
It doesn't feel like, that long ago.
No.
But it has been. And when I think about the work you've done and the journey you've been on, like when you say you love training, I know that because I've seen you do it, and you light up.
Yeah.
Like you turn into an Andrew that is really cool to watch because you feel it's so clear that you're so passionate about it. And now I understand more about why.
Yeah.
Because it's really coming from a place of it's personal.
Oh, very.
And I'll say I was always interested. I was always kind of understanding that ERP, response prevention. Thank you.
Yeah.
Exposure response prevention. What it was and is the treatment for OCD. I knew that.
Yeah.
But it also became a little personal for us in our family. We had a family member that was struggling. Luckily, not to the extent. I think we were able to get knowledgeable and get resources quickly.
Yeah.
But I'm so grateful that I had that.
Yeah.
I mean, most parents don't get that. And most people can't recognize it quickly. And, you mentioned that you had a therapist that was able to say, like, I think this is OCD. It got you on the right track. And so our hope is that more therapists, I'm sure your hope as well, is that more therapists have enough knowledge to recognize and say, this might be OCD.
Yeah.
Let's check this out.
Totally.
And not miss it.
Yeah.
Because the more time that goes by that we miss it, we're letting people down.
Yeah.
And we're also missing opportunities for people to have, I don't want to say relief because you made a good point.
We say like long-term relief, like from
Actually,
hope. Yeah.
That's really what we're talking about.
Yeah.
Is a hope that this can go away. And from your story, it sounds like you were really motivated. because you were in pain.
Very much so.
Do you find that that's the case with a lot of the people that come to you, that they're done with it? Or is it kind of a mixed bag?
It's such a mixed bag. I think, it's funny. I remember after treatment, or not after treatment, but like after we were in treatment for a while with Laura, I was doing a lot better. And she's like, I think she said something to the extent of like, you're one of the easiest patients I've had. Because I was just like at this point where I was like, tell me what to do, please. Like, I need these to just stop. And you'll come to learn that you can't stop obsessions. But I need these to stop being so dominating.
You needed to get on with your life, it sounds like. You wanted to.
Very much
do
so.
more.
Very much so. Like, I knew there were things I wanted to do, and I just wasn't able to do them at that point. And so I would say, do I have patients that come in like that? Absolutely. It's the classic, like, you get sick and tired of being sick and tired type of place. I would say more on average, you're seeing patients who come in a mixed bag of like, yeah, I'm motivated, but I'm also terrified, right? I've had this for a while, and I do have these beliefs that this is protecting me or my family or somewhat to a certain extent. So there is a lot of kind of motivational work you have to do, and kind of working on those underlying beliefs that, that they believe OCD and anxiety are keeping them safe. So
will you tell us more about what OCD is?
Yeah.
Because I think let's not assume that you and I at this point kind of can pick up and know what we're talking about.
Yeah.
But let's start from the beginning.
Totally. And I think that's a great idea. So OCD stands for obsessive-compulsive disorder. I like to think about it. There's two parts to it. You have obsessions and you have compulsions. And obsessions are any sort of unwanted, intrusive thought, image, video, urge, sensation, memory that pops into our brains and causes a bunch of distress. Mainly a lot of fear and anxiety, but just depending on the content of the obsessions, what the actual obsessions are, can be a lot of shame, guilt, anger, sadness, frustration. Now, our body and our brains are built for survival, and we have this built-in fight or flight freeze response. And whenever our brain perceives a threat, we go into this. What's happening is our body starts perceiving those obsessions or those thoughts or experiences as a threat. When that happens, we're designed to fight or run away from that threat. So this is where the compulsions come in. Compulsions are any sort of behaviors a person does to kind of fight or get rid of those obsessions, right? And compulsions can be both physical behaviors, so things you can see someone doing, right? If I was looking at you, you'll think of like stereotypical OCD, someone washing their hands or checking their door lock. But also in OCD, you'll see a lot of people like Googling excessively or seeking reassurance that, whatever they're scared of isn't going to happen, which you'll also see in anxiety disorders as well. And then there's mental compulsions, right? Mental compulsions are those mental behaviors or processes that you can't see someone doing, right? So this could be as simple as counting or praying or trying to think a positive thought to cancel out a negative thought, all the way up to mentally reviewing situations and going over and over something. And then something that I like to talk about is like rumination. It's like you're putting on a detective cap and trying to analyze, why am I having this thought? What does this mean about me? Do I actually want this? And all this kind of stuff.
And those are invisible. Like,
you literally,
you don't know that someone's doing that.
So I think with me, mine, yes, looking back, there are for sure physical compulsions I did, but not like the stereotypical ones that you would think of in movies. But majority of mine were rumination, like completely ruminating, replaying events to see if I did something bad, to see if there was something I needed to confess to my partner at the time. And, it just became a nightmare, and it is a nightmare for people. So what ends up happening is you get kind of caught in this vicious cycle. We call it the vicious OCD and anxiety cycle, where, something triggers you. It can be an obsession. Right? So let's just use like a classic example of OCD of somebody who's really scared of getting sick. They touch, a doorknob, right? And, they get this intrusive, unwanted thought of, oh my gosh, there could be blood on that and I can get some sort of infection and die, right? Naturally, when we're hooked by that thought and we're fully fused with it, right, that's going to trigger a lot of fear, a lot of anxiety.
You're going to die.
Like, yeah, if that's what's going on in your brain, who wouldn't get scared, right? So then naturally, they'll go and wash their hands with soap and water, right? They'll feel a sense of temporary relief, right? They'll get this, but then maybe they turn that faucet off with their clean hand, that dirty faucet. And then, oh my gosh, I just touched that dirty faucet with my clean hand. There could be something on that. I'm getting really anxious. I can't handle this. I'm having this uncertainty, this doubt, this urgency. So I'm going to wash my hands with soap and water. I'm going to turn the faucet off with a paper towel so we're all good. But then they go open the bathroom door. When, it's like, oh my God, I just touched the dirty bathroom door. And then it just goes around and around and around. And this is, that's just one very small example, right? But this is a cycle that anybody with OCD and or anxiety disorders can very much relate to, right?
Right, and when that's 24/7, it's not just like 5 minutes.
No.
That's 24/7. It becomes exhausting and debilitating, and that's when people land in your office.
Yes. And
because we're not talking about like, okay, you're at the doctor's office and you don't want to get sick, so you wash your hands.
Yeah.
Right?
There are situations where it is absolutely appropriate to wash one's hands, right? There's situations where it's not so appropriate.
Yes.
Like sitting in this office or, this podcast room, I don't need to wash my hands after touching this.
Right. But if this was like an operating room, you would need to wash your hands.
Yes, most likely. If I was interacting with all of the equipment and there was blood everywhere, that would be appropriate. Right. So you get caught in this vicious cycle. And I think obsessions are what we call ego dystonic, right? And these are, experiences that we have that are not in line with our morals and values. They are against who we are as a person, as we see ourselves. And this is what makes them so distressing. Because, you may have, I always use the example of like a new mom or dad who has a new baby. Mm-hmm. And, maybe the mom or dad's changing the baby and then they have an intrusive thought of, oh, did I just inappropriately touch my child? Mm-hmm. Right. And that's a scary thought to have. Right. And, this person, mind you, is in no way, shape or form has any history of anything like wanting to do that.
It's an intrusive thought. It came out of nowhere. That's
exactly. Right. But then what happens is the person starts analyzing that thought. Why did I have that thought? Or why did this happen? And then ding, 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 the brain lights up as, oh, that's a threat. Mm-hmm. We need to be on the lookout for that. So, what happens is when we do compulsions, we're basically teaching our brain that those obsessions or those unwanted thoughts are actual threats. And then we never actually are giving ourselves the opportunity to learn that they aren't. Right. Yeah. We can kind of let them go. And something I think that's important to mention is, intrusive thoughts are completely normal for humans to have, right?
That's really important to mention.
Yeah.
I think people come in and feel like there's something wrong with them. Yeah. And sometimes intrusive thoughts take over, and those are the ones that we want to maybe look at more seriously. But sometimes it's normal. It's
very, very normal, and I think it's. Our brain's number one job is to protect us, right? It's like this supercomputer problem-solving machine that's like, what could possibly go wrong and how can we prevent that?
And it's automatic. Like we don't even choose it.
No. And in fact, the more we try to stop them, the more we have them.
Because then now it's not automatic.
We're actively engaging. So, like driving here today, it's super normal as someone's driving to see someone on the, walking on the side of the road to have a thought of, oh, what if I just hit them, right? Mm-hmm. Very, common intrusive thought. The difference, though, is somebody with OCD might be like, why did I have that? What does that mean about me? Wait, do I really want to do that? And they kind of get hooked by it, right?
Right.
It
as
baits
opposed to it just coming and going.
Right, exactly. It kind of just like, because normally you're just like, interesting. And being able to move on.
I got to be careful to not hit them.
Yeah, and then that's about it.
Yeah.
Right? But then, that's your typical experience. But when someone has OCD or anxiety, you're more susceptible potentially to latching on.
And you're stuck.
You're very stuck on certain ones.
Yeah.
So that's what OCD is. I think one last thing with it is OCD used to be called the doubting disease because...
Oh, really? I haven't heard that before.
Yeah. So OCD wants the person to be 100% certain, basically, that whatever it is they're worried about won't happen or didn't happen or whatever it might be, right? And the reality is can we ever be 100% certain in life, right? So you think of that hand washing example, the person's washing their hands to feel 100% certain they're not going to get sick. It's not that they actually are,
but they feel it. It's kind of like a delusion.
It is to a certain extent, right? It's the opposite of acceptance of reality as it is because uncertainty is everywhere. We're sitting
as if we can prevent something.
Exactly, right? And I think a misconception is people with OCD and anxiety are really bad at handling uncertainty. That's not true. They're just not so great at the things their OCD latches onto, right?
Wait, can you say that again? That was really helpful.
Yeah. So there's a misconception that people with OCD and anxiety are bad at handling uncertainty.
Right.
That's not true. It's just the things their OCD and anxiety latches onto.
Okay, so why I think that's really helpful to repeat is that I've experienced where people who with OCD have OCD about something, but really don't about something else.
Exactly.
And I think that the family or the loved ones around get really confused and maybe think, see, you're just
Making this up.
You're just
or,
making this up, or you're just doing this for attention.
Yeah.
Like you're so worried about getting sick from the hand washing or whatever, but you'll like kiss your dog on the lips.
Yeah.
You know, like,
Totally.
or your room is a mess, but you are so worried about, you know, your locker being perfect. Whatever it may be. And it's confusing to the outside.
Like yeah.
So I really think that's an important piece to elaborate for the family members.
Oh, absolutely. And we can talk about family accommodation.
Let's do
definitely
that.
talk about that too. But going to your point of, you know, it's really hard when you're trying to take a logical approach to looking at OCD.
Because it's not logical.
Because it's not. Right? Inherently, when we're in that fight or flight response, you know, a number of things physiologically change in our bodies to prepare us to fight. You know, our heart rate increases dramatically, our breathing intensifies, our digestion shuts down. But most importantly, that logical part of our brain, that prefrontal cortex, pretty much gone, right? And for good reason, because it uses a lot of energy, and we need that energy going to our muscles.
To survive.
To survive, right? The example I always use with clients to just kind of really solidify this is, you know, imagine there was a fire outside the door, right? Like literally right there. Would we sit here and try to logic and be like, hey, Adelina, like, what should we do?
Yeah.
Like,
is there really a fire outside?
Let's really figure this out. Like, no, we'd be dead if we did that, right?
We have to get out.
We'd have to just get out. And it's really hard because when someone's experiencing an OCD episode or an anxiety episode, to the outside observer, you're like, dude, we're just sitting in class right now. Or like, we're in our house in a very safe community. Like, what is going on? But inside, like that brain is perceiving some sort of threat. And our brain can't tell the difference sometimes. Right. And that's what's so hard about this stuff. And, you know, that anxiety one is feeling is 100% real and 100% valid. Now, is it out of proportion to the context? Sure.
Right.
But the brain doesn't know that in those moments.
So then what happens if you're the parent or loved one of the person who's in this very illogical fear or state of rumination?
Yeah.
Because I think that when we love somebody, like I've seen this with parents, they really want their kid to not be afraid.
Who wouldn't?
Yeah, it's like their job,
natural,
like the number one job.
Natural parenting instinct, right?
Yeah, so they try to explain why they are safe and you know why that's not true or not going to happen or whatever, and then actually it feels like it makes it worse.
Yep.
And you taught me something about accommodation. I'd love for you to explain that a little bit. I think that's really helpful for people to know about.
Absolutely. So basically accommodations, well, let me just rephrase this. Accommodations aren't inherently a negative or bad thing, right? Accommodations.
What are accommodations?
What are accommodations first? Yeah. So in the context of OCD, accommodations are like actions or things people do to try to help the person with OCD feel better, right? In that moment. Right? In that exact moment. So, you know, say a kid's really, really scared that they hit someone with their car, right? Because there's like, you know, common ones like hit and run OCD where, oh my God, did I hit something? And then they want to go check. You know, a parent may give them reassurance in that moment of saying, no, you didn't hit someone with your car, right? They may feel a little bit better temporarily. However, OCD, the doubting disease, likes to say, but did I tell them all the information? Like, how do they really know? And then they'll ask for reassurance again. And then the parent will try to logic and rationalize and walk them through. Yes, and give them more reassurance, right? And what it does maybe temporarily sometimes is, you know, softens the intensity of OCD, but ultimately it serves the same kind of function or purpose, if you will, that compulsions do, and that it perpetuates the cycle.
But now someone else is doing the compulsion for you, basically.
Yeah. Yep. So OCD doesn't just impact the person who has it. It really does bring in loved ones, family members, therapists, teachers, whatever it might be. So this is a crucial component when you're working with OCD and anxiety, is to assess and, you know, work on removing these accommodations and teaching parents and loved ones to respond in more supportive ways. Right.
Which I think is really hard to do.
It is so hard to do because your fight or flight gets going too.
Yeah. And it's not instinctual. No. Like when your person is scared and you want to reassure them.
Yeah.
That's like kind of like an instinctual thing.
It is 1,000%. And humans aren't the only animals that do that.
Really?
Yeah, there's been studies on accommodation and like primates and stuff like that.
Really?
That
Interesting.
also, yeah, will like, soothe their loved ones when they're feeling uncomfortable and anxious, right? It's very normal.
Yeah, it's a good thing.
It's a really good thing.
Except when it's with OCD.
Yeah. Except when OCD and anxiety come in and hijack the situation,
Yeah.
right? So parenting somebody or being, with a partner who has OCD anxiety, it's difficult because you kind of have to learn how to go against your gut instincts at times, right?
Okay, I have an example about this.
Yeah.
That I'd love to share.
Yeah.
So you came and trained our staff.
Yeah.
It must have been in the spring.
Yeah, I think so.
And so it was like fresh. Like you had just come maybe like a few days prior to us taking a flight.
Yeah.
And we hadn't flown in a really long time,
Yeah.
Blake and I. Actually, it was the first time our daughter had ever been on a plane.
Wow.
Yeah. That's a whole nother thing in and of itself. But she actually did fine.
Good.
I was struggling though.
You on the other end. Yeah.
Yeah, because we had a flight back in like 2017 that was really a bad flight. And so it kind of stayed with me.
Yeah.
It's been a long time,
Yeah.
but I haven't flown enough. So anyway, all that to say, we're in the air.
Yeah.
Turbulence is minimal.
Yeah.
But for me, because I think I felt very vulnerable.
Totally.
I had my 2 babies with me, my family, I'm like, we're very vulnerable up here.
Totally.
And I'm just spinning. I'm like, not okay.
All these different things.
Ruminating my body, exactly what you described. My body was having a reaction. I was feeling like I had a panic. I was about to have a panic attack. And I keep looking at Blake for reassurance, because he's the person I look to for reassurance.
Yeah, which is totally natural.
Yeah. And the first couple times he gave me like a, we're okay, But then all of a sudden he quoted you and he pissed me off because he was like, I'm going to stop reassuring you now. And because you said something to us in the training, which was thinking about it isn't going to change the outcome. Something like that.
Yeah, something to the extent of like, well, ruminating isn't going to actually stop the plane from crashing.
Yes.
It's
like
it's
you're
gonna
not
crash.
that powerful.
It's not going to. Yeah, it's going to crash. It's going to crash.
Yeah, and you thinking about it won't stop it. So anyway, he quoted you.
Yeah.
And I was like, oh my, I was so angry. Yes. I was so mad because all I wanted was for him to keep reassuring me.
Yeah.
Because that would have felt good.
Yeah.
But he stopped. And I will say, while I was very, very, very uncomfortable for the rest of the flight, I can be, if I'm being honest, it did make me lean back onto thinking about it is not going to change the outcome.
Yeah.
And I kept repeating that to myself. Thinking about, every time I would come in, I'd say, thinking about it is not going to change the outcome. Yeah. Until we landed. Yeah. And then I was like, okay, we're here.
We're good. we landed. We're in Boston.
And on the way back, I still struggled, but I was way better.
Good.
And we're flying more and
you're getting your reps in, your exposures in.
Yes, but it was the first time that I had experienced that. I mean, I was so angry. And it made me have so much empathy and this is like a mini version. Like I wouldn't say I have this grand phobia of flying, like it hasn't stopped me, like I go, you know what I mean? So I'm not trying to compare myself, but I had
to look into the world of what it is like.
Yes. I had a lived experience of how angry and disappointed I was that my loved one wasn't giving me the reassurance. Yeah. And imagine, so I was trying to imagine if this was every day, all the time, how hard it would be, first of all, for him or anyone to always resist.
Oh my God. Yeah.
This was just like a little, tidbit,
if you will.
Yeah.
Yeah.
So anyway, I just wanted to share that because it stood out to me, and it helps me to understand that families, especially parents, I think must really, you work with kids as young as 5, you said.
Oh, yeah.
So tell us about that. What's that like? Because I think it's totally different when you got a little one.
Yeah, yeah. So look, like you said, it's biologically programmed within us as parents to reassure, to keep our children safe, all of that kind of stuff. And that's not inherently a negative thing, right? In situations, so going back to the idea of like accommodations aren't just a negative word, right? It's technically an accommodation when you drive your 5-year-old to kindergarten, right? But that's because they can't drive because they're 5, and that would actually be very dangerous, right? You don't also send your 5-year-old by themselves to the grocery store to shop, right? That's just not something that would be safe and appropriate. Right. However, in the anxiety OCD context of situations, you may have a 17-year-old kid who has their license, they're capable of driving, but they're all having these intrusive thoughts of what if I hit someone with my car? So they've avoided it altogether. So now mom and dad are their chauffeur,
Yes,
if you will.
right.
Chauffeur.
And now they don't have to drive and be uncomfortable and
Yes.
walk through.
Yeah. And so, yes, they are experiencing this temporary relief, but it's really a double-edged sword because, you know, overtly you're basically saying, you know, like, okay, you're safe. But covertly, you're sending this message that, you know what, honey, I don't think you're strong enough to handle these feelings.
If I didn't drive you, you would actually not be safe.
Yes, exactly. Yeah. Very well put. Very well put. So,
but you're not saying that.
No,
it's just the message that the person could receive,
yes.
and probably is receiving.
And repeated over and over and over and over again, right? I always say like OCD and anxiety disorders are resilience killers, right? And confidence killers, because you know you have these worries and doubts. You do a behavior to try to prevent them. You never get the chance to learn that you can handle the feelings or the situations, whatever they might arise.
Your confidence.
It makes you believe
you don't have a chance to be confident.
Yeah. You have no chance to actually learn resiliency, right? And this is something when I'm working with kiddos and parents especially is talking to them about, you know, what are some of the roles a parent's supposed to take on, you know, and typically the usual is, you know, love your kid, provide for them. Of course. Like but ultimately at the end of the day, parents' jobs are to, you know, create a resilient person who can survive without them.
Right.
Right? To be able to thrive on their own eventually, because circle of life.
Yeah,
it's just, like,
that's what you want for your kids, even though it's hard at certain stages to let go.
Totally. Even like this morning, I took my 2-year-old. He woke up and he was in his little sleep sack, and you know he's working on taking his clothes off and unzipping and stuff. And there was an instinct in me to just go and do it for him, right? But I was like, you know, hold on, this is actually, and he did it himself. Did it take like 8 minutes? Yes. But, you know,
how would he learn?
How would he learn? And it was really cute. He was so proud of himself. He was hopping all around and, you know, it's like, that was awesome, bud.
Yes.
You know? So those moments, whenever we jump in to like accommodate or do something for our kid, we're potentially robbing them of the opportunities to learn that they can do it themselves. Yeah. Make sense?
It does. So I have a question about that.
Yeah.
How often do you see like the parents' OCD come in? Often?
Yes, that was with the reaction to So OCD and anxiety, right? We know there's, you know, genetic kind of factors to it. So there's a good chance a parent or family member has it, right? And what causes OCD? There's no like one thing, you know. And it's kind of a couple of things: environmental factors like stressors and those kind of things. You know, seeing how parents or loved ones deal with anxiety. We can also have a genetic predisposition. So if you do have an anxious parent, and every time they're faced with anxiety, they have this urgency and they need to like get rid of it quickly. That kid's going to pick up on that.
Yeah.
Right?
Well, I just wonder too if like the parents' OCD sometimes gets in the way of the treatment of the kids. Like, did the parent also have to get the treatment?
Yes.
Yeah.
Yeah. So I've definitely had a lot of cases. This was more so when I was working at the treatment center, because we were working with like extremely, I mean, it still happens to this day with my practice, but you know, you'd have such anxious parents that would have all their own obsessions of, if I don't accommodate my son, I'm a bad mom.
Right. That's exactly what.
Yeah. Go ahead. Sorry.
No, that's what I was thinking. That I feel like one begets the other.
Mm-hmm. And it really can create like codependence, if you will, too. It's just a whole other kind of discussion, where it's like the mom or dad feels like they can't survive without the kid feels like they can't survive without, you know, and
because that's literally what their brains are thinking.
Yeah. Mm-hmm. And it's running the show. So
what do? You have to treat the parent with the ERP?
So a lot of times, you know, it's a gentle approach because, you know,
it always has to be.
Yeah.
That's what you do so well, is that you're very gentle and like humanistic in your approach.
Because it is, I mean, it's hard.
Yes.
Those alarm bells are going off.
Yeah, it's easy for us to sit here and chat, but this is like people's lives.
Oh, yeah.
And they're struggling.
Very much so. Very much so. So, you know, when we're working with like kids, and even when I'm working with like 13, 14, sometimes 15-year-olds, I'm having parents typically in session because I want them to see how I respond to their kid. Because their kid comes in and is like, am I going to die? I just felt this thing in my throat. Am I going to die?
Right.
And you can see the parents starting to get anxious and wanting to reassure. And I kind of just sit there. And like, yeah, does my heart rate go up and I kind of feel uncomfortable? Sure.
Because you're human.
Because I'm human. And like, it's not comfortable. But I'm able to sit there and kind of coach the parents through like, all right, look, this is, you know, I have a lot of my clients name their OCD. So let's just say this OCD is named Chuck. It's like, oh, it looks like Chuck's entered the room here. It sounds like Chuck is wanting that certainty and reassurance. And coaching parents on, we can validate like, yeah, this is hard to have these thoughts and feelings, right? But you know what? I'm not going to answer this because I love you. And you can get through this. You can handle these feelings.
That's back to the confidence.
Yeah, right. Supportive statements. It's something from the space, supportive parenting for anxious childhood emotions, which is an amazing treatment that was designed for parents and loved ones.
Space, SPACE.
Yeah. Where, you want to validate what they're feeling because that fight or flight's going off, right? They are feeling that. Those alarm bells are ringing. But then you don't want to just jump in and reassure and say, oh, that bad thing's not going to happen. Because to be honest, do we know?
Exactly.
Like that kid could be dying.
Right.
He might drop dead in 2 seconds. Hopefully not.
Yes.
But most likely won't. But you're validating, but then instilling confidence is basically saying like, this is hard. I get it. I see this. You know what? You are really strong. You can handle hard things.
And Chuck is here. And
Chuck.
What do we do with Chuck? Can you, first of all, what do we do with Chuck there?
What do we do with Chuck? So it's a whole, in addition to ERP, well, this is involved in ERP, basically. We want to help the clients get from a resistance and struggle stance with their thoughts and feelings to a much more acceptance, willingness stance. Okay. Right? So kind of slowly coaching the client, a lot of psychoeducation about our thoughts and feelings, and they're not dangerous and all that fun stuff. But a lot of like interventions of practicing acceptance and willingness of like, oh, hey, Chuck, I see you're here. Like, thanks for stopping by. And almost even getting to the place of like, you know what? Come take a seat on my shoulder. Right?
You're welcome.
You are, yeah.
You can be part of me.
Absolutely.
But you're not all of me.
You're not, no.
You're not me,
You're
actually.
not me. You're not me. You are, my brain is doing some stuff and I'm myself, right? This is just kind of a part that's chatting away and trying to protect me. It's just doing not such a great job. So like, for example, as we've been sitting here in this podcast, hopefully I've seen present, but like, I've had intrusive thoughts, right? Bitterman has been like, oh, your career's going to end, they called you an OCD expert. Are you really an expert? Are you a specialist? What would even determine it, And I could sit here and start arguing with that.
With
right?
Bitterman.
With Bitterman, right? But like, then I won't be able to actually engage in this really important, values-based, activity that I really want to do and spread awareness and help people who are dealing with this. So it's kind of like, it's almost like pull up a chair, Bitterman, like come sit. And,
come on, Bitterman, join the conversation.
Join the conversation. You can be here, I can see you there, but I'm just going to choose not to actively engage with you. Right?
So what do you think it is about, I love this.
Yeah.
I love this this part of the intervention.
Yeah.
Blake and I are trained by Violet Oaklander. She's a Gestalt play therapist.
Yeah.
And so much about her work is the parts, like the different parts of you and owning all the parts.
Yeah.
And you don't have to like all of them for them to all be part of you. So
they are there.
But they're all there. Yeah. And they're all welcome. Even if you don't like some of them at moments, but they're there to help you. Anyway, it reminds me a lot of the work that we do in that way. It's similar.
For sure.
What do you think works about that for OCD?
Yeah. So basically going back to that fight or flight response, right? That survival response of escape, get rid of. Mm-hmm. That's really good when there's actual external threats, right? So if there is, say you're walking your dog and there's a coyote, you cross the street and you go the other way and that threat is gone. Mm-hmm. What happens though is with OCD and anxiety disorders, we start perceiving our thoughts, our feelings, our sensations, our memories, all these, we call it like our private experiences or inner events, right? We start perceiving those as threats. Can you really escape or run away from yourself?
Right. That's okay.
Yeah.
Oh, so you externalize it so that you can have some space to run away.
Well, no, not to run away.
You don't want to run away.
You don't want to run away from it.
But you're separate.
You are being able to take a step back, if you will, and observe like, oh, look, my brain is throwing this stuff at me. I've been doing all these behaviors, these away moves, if you will, trying to distract myself, compulsions, sometimes like drinking, drugs, whatever it might be, to not experience them, right? When we do that, we get that temporary relief, but we're never giving ourselves the opportunity to learn they aren't threats, right? So ERP essentially is let's open up and lean into and breathe into, if you will, these inner experiences, these thoughts we don't want to have that we deem as threats, feelings, all that kind of stuff. Because then we get to actually experience that they aren't. They don't hurt us.
Oh, I see.
Right? So it's all about that brain perceiving those thoughts and feelings as threats when they're not.
Right. And then experiencing it and not dying.
Basically.
And learning that it's than it wasn't. Actually.
Exactly, right? Now, that doesn't mean that there aren't emotions and or thoughts that are unpleasant or that we don't want, right? It's hard being a human, right? We, if we live long enough, we're going to experience some extremely great moments,
Totally.
and some horribly tragic moments. Like I lost my aunt this past weekend, and it sucks. It really sucks, and cancer sucks. But I was having to really practice what I preach to my clients. Were there parts of me that were wanting to really run away and distract from the sadness? Sure. And also I was trying my best and being compassionate with myself and allowing myself to actually experience the sadness and create space for it, while at the same time practicing kind of like some gratitude of being with my family in this and being able to connect and, celebrate her life, if you will. All of that can exist, right? And a lot of times with OCD, there's a whole bunch of like underlying beliefs of people with OCD that I can't have a good time if these obsessions are here. I can't be present. I can't do whatever it is. If I'm having these worries and anxiety, I can't. And it's really about teaching clients that you can coexist with it all. And we get to choose where we, put our attention, right? Almost like a spotlight.
So is it kind of like both can exist and you can still go on?
Because the reality is they do exist.
Right.
Both do exist. In the struggle mode and the get rid of mode and the compulsion avoidance mode, it's denial of reality as it is. You're trying to get rid of something that's there and trying to pretend like it's not. And you're putting all this energy and attention on it, right? Versus, no, I'm accepting that these thoughts and feelings are here. It doesn't mean I like them or want them, right? Or agree with the content of them.
Right.
Right. It's they're here right now and I get to choose what I do in this moment.
Going back.
Does that make sense? I know it could be a little like heady and a little confusing.
Well, it makes sense to me.
Yeah.
I think I follow. But it is confusing.
It can be.
Like it's like a lot of this because you can't see it.
Yeah.
Sometimes.
Yeah.
I know some of it you can't see.
Yeah.
Like in movies, right? I think people colloquially very much say, "Oh, I have OCD," or "They have OCD," because it's so simplified in the media.
Yeah.
Like people think, I don't know, it's not OCD because they don't wash their hands or they don't move things perfectly or whatever. There's so many you taught all of us at Engage, like there's actually so many different forms that are so tricky.
Yeah.
And now that I know what I know, I see more, and so does our team.
Yeah.
Like we'll be sitting there, and I'll see how my colleagues are thinking differently about what's showing up,
conceptualizing and stuff. That's awesome.
We would have totally missed because it just looks like, oh, this person's just really anxious.
Yes.
But then when you start to really listen to the nuances of how it's a spiral and a loop and they're stuck, it's the stuckness that I think when you feel as the clinician or as the parent that you should cue you to be curious and wonder if perhaps there's more going on.
Sure.
And then another thing you told me too, a long time ago, is that sometimes typical interventions for anxiety can actually exacerbate OCD. Can you say a little bit about that? I found that so helpful.
Yeah.
and kind of fascinating.
Yeah, absolutely. So, a lot of in therapy, cognitive behavioral therapy, there can be this thing of like cognitive restructuring where you go and you challenge or look for the evidence for a thought being true or not true or the accuracy of it. This can very easily turn into compulsions because inherently, say someone has an intrusive thought that, they're in their kitchen with their family and they're cutting some steak and they have an intrusive thought of I could take this and stab my mom, right? Our natural instinct is going to be to fight with that thought. I don't want to do that because I'm a good person and you know what, I would never do that. But then OCD chimes back in with, but you never know, anything's possible, right? But then you argue back with like, no, because I've never actually hurt anyone. But this could be the first time you do, right?
Why'd you have that thought then?
Why did you have that thought? What does it mean about you, right? And inherently, you're already trying to argue the evidence in those moments. So those traditional CBT interventions of like looking for evidence for, evidence against can very easily feed into it. I still teach those kinds of tools with the caveat that, and this is kind of like the really, really important piece of, it's not to gain certainty, right?
Oh, okay. That's
right.
The difference.
That is the huge component there where people will use these interventions to be like, no, for sure not. I'm not going to stab him. Right. And realistically, they're not. right? But OCD, you can be 99.99999% certain.
It's not enough.
It's not enough, right?
Okay, so it's not for certainty. So what is it for?
It's really to help them, going back to how I said earlier in the podcast, how people handle uncertainty just fine,
Right.
just the things their OCD latches onto. It's to be able to help their mind get there. I use the example with my clients all the time of like, if they drive, of is your car in the parking lot?
Oh, yeah.
Right. I did that, I think, at the training, right? And everyone's like, yeah, it is. Absolutely. And I'm like, well, can you hear it? Can you see it? What are you, and they're like, no, we can't. So is there a chance something happened? Well, yeah, there's a chance it got stolen or towed, whatever. Then I ask, like, but are you spending all waking hours trying to make sure your car is in the parking lot to be certain? And they're not. And I ask, like, what would your life look like if that's what you were doing? They wouldn't have a life because that's all they would be doing. So it's inherently learning how to teach them, look, is it possible that your car is stolen? Anything's possible, right? Given the actual circumstances, though, that we're in a safe neighborhood. You haven't heard any alarms. There hasn't been previous break-ins and all that kind of stuff. You're probably okay, and you can come back to what's important. So using like cognitive restructuring in that sense of like, look, that thought is telling me this, like, given the situation I'm currently in, we're most likely okay to ignore this, if you will, and kind of leave this. That's one of the ways to kind of use it, but it really can be misused very, very easily.
And I think if a clinician doesn't know that, they might accidentally, not intending to, but might accidentally feed an OCD. And this is the part that I find really, like, I struggle with, is that you may not even know it.
Totally.
Because it would require the person sitting in front of you to explain that to you.
Yep.
And they, I think, mostly maybe don't even realize it, or would never say it because it's protecting them or whatever it may be.
Well, and I really like to think, like, I really do believe everyone, the clinicians, have their best intention. They want to help, right? And it's just kind of a simple fact of, I think, not knowing at that point. Right? We're not taught this stuff in grad school.
I know. Why aren't we?
I don't really know.
Let's change that. If there's a way we can change that, we should, because it's a disservice.
It is.
To our clients if we don't know, because we learn about all the other stuff. We learn about CBT and DBT, all theories.
It's funny though, because like we do, but do we really learn that much?
That's true. We learn, but okay, at least we know that the other things
exist. Yeah, that they're out there.
They're there to learn more about.
Yeah.
I haven't been in grad school in a very long time. So it's possible that they are teaching that.
I mean, I wasn't taught. I mean, we learned in our DSM class, like a half of a class, what OCD was, but it wasn't. It was the professor talking about stereotypical OCD, and the ERP was never mentioned.
Is it new? Is ERP a new thing?
No, it's been around, I think, since like the 70s.
So how? Yeah, why is it? Why doesn't it have bigger?
Well, this is a whole can of worms we're opening here because.
What is it?
Well, when you
focus medicine.
No, well, maybe, I don't know, but exposure therapy. When you hear the word exposure therapy,
people don't want to be uncomfortable.
Yeah, right. Exposure therapy has a lot of misconceptions. Behind it, like, people, oh my God, it's traumatizing. It's mean. It's cruel. It's forcing patients to do these things.
Yes, that's true. People do think that.
Yeah, and I have to. So much of my work in the beginning with clients is breaking down those barriers of like, no. Exposure therapy is the most compassionate thing you can do for yourself. Slow, and we're not forcing people to do things they're not willing to do. We're looking at what's important to them, their values, and guiding exposures through that.
Right.
Yeah,
but I think back in the day, or at least, again, based on the media, you're right. Some people think like, you're afraid of a snake, you need to go hold a snake.
Yeah, we're going to fear factor it.
Yes, fear factor, exactly. Yeah. Whereas that's not at all what it is.
That's the sexy version of exposure
therapy,
right?
Because it makes people watch a show.
Exactly.
And it's like, you're right. It's entertaining.
It's way more entertaining than, just kind of like touching something like this.
Or looking at a picture of a snake.
Exactly.
Or even saying the word snake. Yeah. Like it could be, you start really light so that it's never out of someone's comfort zone, but it's enough. Challenge.
Well, it's honestly, I think the working out analogy is so perfect with it. Like if you've never ran in your life and you ask someone to run a marathon,
They're
like,
gonna.
Yeah.
It's not gonna work.
Good luck.
Yeah.
But like if they've never run in their life and you ask them to run, 0.3 miles, maybe that's a bit more possible. Are they going to sweat? Is their heart rate going to increase? Yes. And that's
But that's
good.
the point, because then that kind of builds your tolerance to then the next level.
And you work your way up. Right?
Yeah, that's a good analogy. We do get, I will say, I don't know if I've told you this, but we do sometimes get resistance from families when we refer to you.
I'm sure.
and we have to do some psychoeducation and teach and say, no, it's actually not what you're thinking.
Yeah.
But also sometimes the person who's suffering says, you're going to take this thing away from me. I don't want you to take it away from me. So I don't want to do it.
Yeah.
And it's not until they get motivated or it gets serious enough that they'll go.
Totally.
But that's the part that I think we've seen as a little bit of a struggle.
Well, what I think to kind of, counter that, if you will, but there are some clients that I've seen for, sometimes we don't even start ERP for at least a month and a half, sometimes even 2 months. If they're not there.
You're just getting them ready.
Yes, we are working on a lot of acceptance strategies, mindfulness strategies, a lot of motivational interviewing. I love ACT, so a lot of creative hopelessness kind of exercises to help them learn like their ways aren't sustainable, right? To help them get to that conclusion. To
then have motivation to do it on their own, because they have to do it. No one else can do it. And that's the other thing I think is important for families to hear, right? Is that the family can't do the ERP for.
Well, yes and no. So like this is where space comes in.
Okay.
Right. So if
I don't know much about space.
Yeah.
Tell me
about it. So basically it's all about removing the accommodations that family members are doing. Accommodations are, pages and pages long typically when you go and look at what accommodations are happening with families. So what you're doing in this sense is you're working, if the client, I have like 3 cases right now where I'm not even seeing a patient or the client, I'm seeing the parents. And we are going through and charting all these different accommodations they're doing for their kid, right?
And does the kid know that the parent's doing this?
So yes, we make an announcement. We give them a letter basically saying, mom and dad love you very much. You're an amazing kid, and we also see how much this OCD and or anxiety is debilitating for you. So mom and I are working with, Andrew Cohen, and, stay tuned. We'll be letting you know kind of some changes are coming, right? And we love you, right? So every time we pick an accommodation to remove, we're making an announcement to the kid. It's not a discussion, right?
It's an announcement.
It's an announcement.
I noticed you said the word announcement.
Yeah, it's an announcement. It's a unilateral decision from the parents to the kid, because ultimately, if the kid's not willing, the parents don't have to be slave to OCD and anxiety. Right?
Because then it becomes this negotiation that's not going anywhere.
Exactly. Now, I much prefer if the kiddo is willing to participate in treatment and we can come to that together. Yeah. However, what I find a lot with space when I do this is, yes, it starts out a lot with just parents, but then once accommodations start getting removed, the kids or young adults or whoever it may be kind of start to realize, oh my God, like OCD really is debilitating for me. Because I've had so many intakes where kid comes in, I'm doing, my assessments with them, talking about OCD. They're like, no, it doesn't bother me at all.
I'm fine.
I am so good.
Everything's good.
I'm able to go to school. I'm able to play with friends. I'm able to do this. Then you bring the parents in, you look up the accommodation scale. It's like, huge. Everything. They're doing everything for the kid. They're getting the clothes prepared. They're texting their friends for them. They are doing the homework behind the scenes. They're doing all this kind of stuff. Literally. And unfortunately, this, understandably so, creates a lot of tension in the house. A lot of resentment builds also to the client, because it's like, oh my God, we're doing all this for you, right? So I forgot kind of what we got on that topic, but with space, I guess we are working.
Oh, I was saying about the parents and how their role, I guess. So you
there is hope if your kid is not willing to. So say you do have a client who really is, they're just not there. We work with parents on that.
That's so good to know. I actually didn't know that.
Yeah.
It would still be my first call. And I guess you would just do that, but that's good to know.
Yeah, no, and it's been a game. I mean, it's a game changer because, a lot of times it's like, oh, my kid's not willing to do treatment. It's hopeless. Like it's a lost cause. Oh, you have to wait for them to be ready. But there are behaviors that parents are doing that are potentially facilitating no change. Yeah. Right. Whereas.
And you're not blaming the parents. It's not their fault. You're just helping them to get out of it.
Well, it's and I phrase this, it's all coming from this very deep love and not wanting to see your kids suffer. Right. And it's, it isn't their fault. Yeah. But I like to phrase it as like, you didn't cause this, but you can be a huge part in solving this.
Yeah.
Right.
I have a question for you, actually. I think I've asked you in offline, but
Yeah.
tell us what you know about PANS and PANDAS.
Yeah.
Because I think that's another thing that therapists don't know enough about.
Yeah.
And it crosses over largely
Yeah.
in the OCD world.
Yeah. So I'm going to totally butcher the pronunciation of these conditions, but PANS, I believe, is pediatric acute neuropsychiatric something. Oh God, blanking on it. Basically, what they are infections that go through the blood that like sicknesses people get, strep throat or other kind of infections.
Like a virus.
A virus of sorts, yeah, a virus that can cross the blood-brain barrier and kind of impact parts of the brain where OCD kind of lives. And a lot of times you'll see parents come in with kiddos and they're like, my kid went to bed and they woke up the next day, or like very quickly soon after, a completely different kid, in debilitating OCD symptoms. But not only that, a lot of times there's extreme emotional dysregulation, anger, irritability, just huge mood swings and those kinds of things. And whenever a kiddo comes in, I did an intake kind of recently, I think, where they were talking about like, oh, he's had like 10 strep infections like in the past year, it's like, okay, well, let's go.
That'll cue you.
Yeah, something. If
but
there's
what
been
if parents don't make that link?
If that he's been sick, well,
Yeah.
when I assess, when I'm
that
assessing, I'll ask about like symptom onset, like how quickly did this happen? Was this like over years? Was this like overnight? That'll kind of gear me towards, is this PANS? Is it not? Also, if there's a lot more comorbidities too, maybe more irritability and things like that, we'll look at potentially that. So, you have to get kind of evaluated by a pediatrician. You also have to be careful who you go to, because there's some pediatricians that don't believe PANS and PANDAS exist. It's controversial in that world.
Do you know why?
I honestly, that would be a good question for my brother.
Yeah.
I don't know why.
Well, I mean, I've asked a couple pediatricians myself,
Yeah.
and I don't know that I have an answer to why, but something about the research on it. Something about the research on it being doubted.
Okay.
And
like
so-
the setup of the trials and all that kind of stuff,
I don't know the details, but
Yeah.
something like that.
Okay.
And it's just too bad, I think.
Yeah. Yeah. Well, because I think, it's funny. I was at so the IOCDF does what's called the Behavior Therapy Training Institute, BTTI. So
Okay.
I was in one of those trainings, and one of the psychiatrists there talked about, she does believe PANS is real, is a thing. However, she thinks it's overly diagnosed.
Oh, okay.
Yeah.
Okay.
So like a lot of times people will jump to like,
So there's
oh,
a
it's
resistance maybe. Like, everything's not
PANS. Exactly. Right. So I think there's skepticism.
ADHD,
Yes,
same thing.
exactly. Or everyone's, autistic or
yeah.
whatever it might be. So I think there's that component to it. But I'm actually, my brother's coming out today. I'm going to talk to him about it.
See what he says. Because
Yeah.
I think in med school, we were talking, they don't teach us in grad
Yeah,
school.
no.
And it sounds like they don't really maybe teach it in med school either. But that doesn't mean that it doesn't exist.
Absolutely,
And
absolutely.
I think clinicians tend to be the first line of noticing because of the sudden.
The sudden,
aspect
yes,
of it.
absolutely. Well, and so treatment, you're still going to be doing ERP, right? So
Yeah.
like from the behavioral therapy component of things, not much different. But you do need to get, that underlying infection treated, and figuring that kind of stuff out. And there's something called like IVIG. I think it's like IV treatments.
That's for more intense cases.
Yeah, and it's not covered by insurance. It's very expensive. And I think that's also where the controversy lies too, is like,
Right.
does it work?
Yeah, yeah.
Does it actually work or help? I think there's cases where it has, there's cases where it hasn't, and people are spending thousands of dollars. So,
And I think that there's also a component of autoimmune disease in there. And I think autoimmune diseases in general, just there's not a lot of information about.
yeah, that's fair. And I mean, I it's hard to, I'm going to preface, I'm not a medical doctor, it's so
Neither
hard.
am I.
It's
And
so
I don't,
hard
I just kind of know what I have figured out over time. But, we're going to be talking to a couple pediatricians on here.
Yes,
So
that would be
I'll find
amazing.
out more.
Please get, I don't want to be like RFK Jr. over here and claim things without any actual.
I mean, we don't know that the fact is that there's a lot of things that we don't know about.
Yeah.
And this is just one of them.
Yeah.
But the reason I wanted to ask you about it is because of the treatment.
Yeah.
So the
yeah.
treatment is the same.
From my perspective,
your perspective.
ERP, yeah, you're looking at now, because there's other comorbidities potentially, like higher irritability and those kinds of things. There might be more other therapies that need to be thrown into mix, DBT, emotional regulation kind of skills.
Right.
In
addition to.
In addition to the ERP. Yes, absolutely. And sometimes, because ERP is inherently can be dysregulating. So sometimes we need to get them like a base layer, if you will, of better strategies to manage big feelings before we even dive into ERP. Right.
Yeah. And I think that, again, so like you get rid of the infection, right?
Yeah.
And then you do ERP, and then what? Does it go away?
Well, so I think the thing is, if they get sick just throughout their lives, it can kind of flare up.
Got it.
Right.
So, and that's the autoimmune part.
Yeah. I
think.
Yeah, maybe. I'm not totally sure how on that back end it works like that, but I mean, it makes sense.
Yeah. Because there's a flare.
Yeah.
There's an inflammation or a flare of that thing. Yeah. I agree. I'm also not a doctor.
Yeah.
But it's unfortunately, I feel like in helping a lot of my clients and actually my friends, I've become sort of knowledgeable about this.
Totally.
But I will say there's not like this article I can go read because there's not a ton of them.
Yeah.
And I wish there were.
Yeah. I mean, there's, the IOCDF has good information on PANDAS. I think there's like the PANDASnetwork.org or something like that.
Yes.
That's a good resource. We're
gonna put all this in the show notes.
Oh, perfect.
So that people can reference it if they'd like. But I think that's what really got me more tuned in to OCD and to ERP.
Absolutely.
Because we work with kids. We work with young kids, and I think there is a huge difference when someone says that their child has always been this way from the beginning. Yeah. There was like little pieces. Versus someone who's completely functioning, no struggles, and then all of a sudden. And I think there's like an age range, like it's like 5 to like 10 or something. That
honestly, that I'm not totally sure about. That's
okay. I'll who is actually really knowledgeable about this? Melissa Mose, yes. And Tanya Altman too. She's a pediatrician.
Okay.
Yeah.
I need to connect with
She's
her.
great. And she taught us a lot about this.
Awesome.
Yeah. Back at actually in 2018.
Okay.
She taught us about that, maybe even earlier than that.
Yeah.
And because we work with kids, sometimes I think like, man, I love that you work with kids as young as 5.
Yeah.
Because I think a lot of people don't.
Yeah.
And
I got to be honest, when we're working with kids that young, the majority of it is parent accommodation work.
Always. But that should always be the case, by the way. Like we work with kids that young in play therapy, and we still include the parents in this for the same reasons you described.
Yeah.
But I just think in my career, like I think back and I'm like, man, how many times did I miss this? How many times did I just not know enough to help some kids that I was working with that now I wish I could go back and redo that and help them more. But anyway.
No, I mean, let me talk about our minds. It's such an easy spiral to fall into if I could,
Sure. But what I do is say, well, teach people about it now.
Yes.
Do what I can do to help more therapists know. That's why I wanted to ask you about it.
No, it's great. And kind of that's going back to the OCD kind of thing. That's why I'm so passionate about teaching this stuff too. Because
so you don't miss it.
Yeah. I mean, it takes an average of 14 to 17 years from symptom onset
to
being diagnosed and getting the appropriate treatment. Yeah.
That's a long time.
That's a long time. Yeah. So I started having symptoms at 6 or 7. I got diagnosed at 23. I think I fall kind of right in that.
So what about your family? And your family's lovely. I love your family so much.
They're so sweet.
I wonder what their experience was with
me?
knowing that this was going on. Did they know all the whole time? Because it was in your mind.
Yeah, I mean, they knew I was anxious, but also we're, neurotic Jews. I think all of us are anxious.
So you blended in.
Yeah, I think we just fit in perfectly. My mom's always the one who's like, knock on wood, knock on wood, knock on wood, right? So, talk about that learned component of it too. But what was I going to say? I think it started out more as like bad separation anxiety. And I think they just kind of looked at it like, this is
Andrew loves us so much.
Yes. And like, he wants to sleep in the bed with us. And that's so sweet. At 15 years old, when it's either wanting to sleep in the bed, that's also not the sweetest.
Right.
But I think it was like looked at. And around that time, that's when I started going to therapy. But I didn't even know the extent of it really until I think, like I said, that's that last year at UCLA when it just really hit the fan. Like everything I couldn't function. right? Up until that point, I was getting by, but there were so many compulsions that I was doing.
To get by.
Yes, but I didn't realize they were compulsions. I didn't know what I was just like, this is what I have to do to keep going, right? And then it just hit ahead. And I think at that point, we were all like, uh-oh, something's not right. You know?
So did your parents or your family say they were worried about you and they said it? Or did you have to kind of come to them and say, you know what, I'm doing all this stuff that you don't even know about in my mind?
So I think it was more of externally, like I was clearly not doing well. Like you can see just if you talk to me and all that kind of stuff. So they saw that. I don't even think I'd be able to like explain or even had kind of the insight to realize what I was doing in my mind. You did. It felt out of my control, right?
It was happening to you.
Yes, like
it felt like
I'm bombarded by these intrusive thoughts of, oh my God. It's like, for example, I had a serious girlfriend in college, and I would get bombarded by like an intrusive thought of, oh, that girl might be prettier than this your girlfriend, so you have to go confess that. Or you had this thought about another girl, that means you're a terrible person. You got to go confess that, right? So it just literally, it's that process I just described. It didn't feel like that. It was literally just like being hit with a brick, and like I got hit with a thought, and I just confessed. And
it was your reality.
Yeah.
Now you can talk about it as separate from you, but at the time you were consumed with it.
Consumed.
Like what's the phrase that a fish doesn't know that they're in water?
Yes.
Right? You're just
I guess
in it.
That is your
their
world.
world. They don't know something different.
Yeah. So that was very just much, every day for a while. So I think obviously they started seeing I wasn't doing well. And, there were times where, I would just have complete breakdowns, and my girlfriend at the time would have to call my parents to come get me. My last week of college, I just remember trying to party as much as possible just to not have any sort of thoughts. And obviously that didn't end well, because you sober up eventually.
Yeah, and they came
right back.
It didn't drown bitamin.
No, bitamin, there's the rebound effect. I like to describe it like, when you try to do stuff like that, it's like trying to put a beach ball underneath the pool, and the farther down you push it, that rebound effect.
You're so good at these metaphors that it really helps people to at least me, to like have a visual. Understand it.
It's that's why I love to act. That's why I love act so much, to be honest, too.
So they must be so proud of you.
I think so. I mean, yeah, no, they are. And it's, it's sweet. It's cool. I think my parents, I love them to death. They are, I think, the classic example of parents that just love their kid and were trying to do what they can. Now looking back, did they reassure me a whole bunch and do that kind of stuff? Yeah.
They didn't but they were doing their best that they could do. Yeah. Do what they knew how to do.
Yeah. And now, my parents and my dad, and, they know more about this stuff, and, they're even with their own lives starting to try and,
that's so
work
cool.
on it themselves. And I think that's really, that's, if I don't know, the silver lining of all this is like,
it helped your whole system.
Yeah, the whole family system. And, I think my parents can be very proud. They got the therapist, the doctor, the teacher, tutor,
helpers,
a whole bunch of helpers in the family.
Yeah. All amazing human beings.
Yeah. And I'm very, very lucky and blessed to have that. It's really nice.
Yeah,
really,
I mean,
really nice.
The reason I think they must be so proud of you is because I am so proud of you. And I am not your parent. But I really...
I mean, you were, what's it called? An essential step on the journey of it. I mean, I was there for, in total, how many years?
Yeah, because
6 years, and then worked in private practice there. And
and you did groups. Mm-hmm. I remember.
Yeah, it was the case man. No, what was the call?
Yeah. It was called case manager at the time.
Yeah.
But you know what? I didn't know that you had all this struggle underneath the hood. Like I really didn't. You hit it pretty well.
And most of us do, right? I don't know, the ins and outs of your mind,
exactly what I'm
Blake's mind.
It's a good reminder that we don't know what people are dealing with. Like I would have never known this.
Yeah.
And now that I know, I'm like, wow, you were doing stellar. I mean, I thought you were doing great no matter what.
But
knowing that bitumen was there and knowing your journey to get wow, it just makes it even more impressive. So it's a reminder to be kind to people.
Yeah.
And you don't know what they're dealing with.
Totally.
Whether it's something like this or like a death in the family or just worries about a loved one,
anything.
You just never know.
Yeah.
I always tell people about you. I try to introduce you to as many people as I can because I want people to know you and have the resource in you.
Yeah.
So anyway, thank you.
No,
for being here.
I appreciate, you guys having me, and it really is cool coming here full circle. And, I'd love to come back and talk about a whole bunch of different topics. And, any time. So yeah, it's been great.
Sounds good. And tell Bittaman thank you.
Oh, absolutely.
For letting us borrow.
Yes, absolutely. Hey, I owe kind of my livelihood to Bittaman, though, if you think about it.
There you go. Look at all the stuff you've created because of Bittaman.
Yeah.
Thank you, Bittaman.
Thank you, Bittaman. Exactly.
Cohen OCD Therapy would not exist if it wasn't for Bittaman.
No, it really wouldn't. I don't know what I would be doing.
Yeah, and you have trained other clinicians in our community.
Yeah, and we got associates that work with us, and we just hired a new one who's I'm training right now, and it's really cool.
It is cool because if I know that someone was trained by you, it does give me a certain amount of confidence in their training.
Yeah,
I do think a lot of people in our field, unfortunately, consider themselves an expert because they had an experience themselves. And I think that, yes, in a way,
that gives you personal knowledge of the discipline.
It can also be very triggering.
Yes.
I know for myself, there are certain things that if it comes up in my office, I'm wary of because it's a little too personal for me. It'll a lot of and I've seen people sort of let that kind of take over. It's really hard. You have to get really good consultation and supervision to not over-identify.
Absolutely.
But I think what you did is, yes, you have your personal experience and you have this really solid tool under your belt that you use, and then now you can train other people in it.
Yeah, exactly. No, and it's, when I commit to something, I go in, if you will. So, we'll see what the future brings.
Yeah, let's see what happens next.
It's uncertain, and we got to.
All I know is that you're helping people.
I like to think so.
Thank you for that. And thank you for helping us, and just thanks for being here today.
Yeah, no, and you guys have made, talk about proud. You guys created this whole thing. This is just, that's awesome. You guys are a force to be reckoned with.